Hello, thank you very much for the invitation to attend and talk here. As mentioned, I'm Catherine. I'm a consultant haematologist doing a locum job down in Eastbourne. Prior to that, or a few years ago now actually, I did a PhD in haemostasis, and particularly in novel treatments in haemophilia. Again, the talk slightly belies what I'm going to actually talk about. When Paul invited me to give this talk about global haemostatic assays, I have to confess I panicked a little bit. And I initially thought he wanted me to come up with something so brilliantly succinct I could tell you about this whole subject within 15 minutes. He knows me though and knows that I could definitely not do that. So instead, I've turned to a bit of a personal review of my experience with global haemostatic assays, really as a demonstration of how, as a clinician, my skills in the lab evolved going into a research project. So I hope this will fit with the theme of developing careers in research for the medical trainees in the room. In order to answer the very practical clinical question that I had to develop the tools to answer it and develop an understanding of the drawbacks of all the different sorts of assays available to me. So I would hope to outline the sort of process of evolution that took place in this research project, reassure you that if I can haplessly muddle my way through developing laboratory assays, then anybody can, and in the process hopefully obliquely raise your awareness of some of the options of global haemostatic assays out there. So in order to explain why I spent so much time looking at global haemostatic assays, I wanted to summarise the background for my project, for my PhD, and the clinical perspective I was coming from. So here goes my attempt in just 2 slides. The title of the project was Clot Stability and Novel Therapies in Haemophilia. The work was really based in appreciation of the cell-based model of haemostasis and then the notion that haemostasis is a sum of its parts. What I mean by that is that to get a functional clot, all the processes that contribute to cellular function, thrombin generation, the assembly of the fibrin strands, fibrinolysis and the termination of the haemostatic process all need to be working in perfect harmony and concert. So following on from this, it's too simplistic to think of bleeding disorders like haemophilia as a simple factor deficiency that leads to thrombin generation and that's the end point, or abnormal thrombin generation and that's the end point. The defect in haemostasis goes far beyond that, affecting all the stages of the coagulation hemostatic process and resulting in a central pathological defect, which is the formation of a dysfunctional clot. So that's what I wanted to encompass in the sorts of assays that we were developing. My rather clinical question was, could this understanding of hemostasis be exploited to develop new approaches to treatment? So rather than the standard approach to treatment, which is focused on replacing the thrombin generation, restoring those patterns, could we explore ways of manipulating clot stabilizing mechanisms or affecting the way hemostasis is terminated in order to develop novel approaches to treatment? So to start to test these sorts of possibilities, I needed tools, and as a clinician, unlike Professor Hunt, I had very, very little experience and exposure to laboratory work. This is what I was happy with in the lab, and this is what I felt comfortable using. These basic tests are great on a clinical basis, on a day-to-day basis, but are really performed in quite unphysiological conditions, in plasma, providing really the briefest glimpse of the hemostatic process, that initial formation of the fibrin clot. What I felt I needed was something a little bit more like this. Rightly or wrongly, my aim at the beginning of this project was to find an ideal global hemostatic assay. I should point out that this was my vision at the beginning, and I'm not going to comment on whether it was very realistic or not. And there are other definitions out there, but that was what I felt I needed to really reflect this understanding of hemostasis and how we were going to manipulate it in order to affect the clot function. So what I wanted to do was find some way of providing a test that accounted for all these physiological and physical factors influencing hemostasis and ultimately resulting in a functional clot. As with a name like that, I did set myself up for failure, but along the way I did evolve skills and experience with using a variety of assays and appreciation of the steps that you need to take in order to develop at each stage. And I think a respect for the value of failure, trial and error and failure, and learning as you go through. So I wanted to share with you, first of all, some of the tools that I did use, some of the manipulations that we made, and where we ended up in the end. So the first global hemostatic assay I had access to was thrombin generation, and I imagine quite a lot of people do have that machines that can provide thrombin generation data in their laboratories. This can be performed in plasma, it can be performed in whole blood. It's either through a continuous fluorometric assay or with subsampling to look at thrombin complex formation. I used a continuous fluorescent assessment in plasma. Here's an example of the sort of data that's generated. It gives you a great deal of extra data beyond just the initial clot formation and the standard laboratory tests. And I was able to quite quickly, clearly demonstrate differences between normal and abnormal plasma and thrombin generation. The great advantage for me coming into research was this was automated and well validated. I could practice my pipetting techniques, but the rest was very well set up. It has a dynamic property to it, so at time dependent you get a great deal of information about how the process is evolving. And with the particular assay I was using, you can do multiple interventions. It's quite a time effective tool. In common with all of the hemostatic assays I'm going to talk about, there's the effect of the pre-analytical variables that we had to learn to cope with making sure that samples were carefully procured and managed. But beyond that, it did have its own particular drawbacks, and for me, it was providing, as I said, a great deal of information about the thrombin generation process, but it didn't feel particularly global. Where was the assessment of the role of the platelets or the endothelium, or the assessment of the ultimate clot structure and its function? So I started to look around for an assay that could include more of these processes, account for more of these elements. And I turned to probably the second most commonly used global hemostatic assay out there, which is viscoelastic assays. And I didn't have to look very far because I was working in a lab which had 5 rotems. So for those who aren't particularly familiar with it, this is a picture of what's going on inside a rotem device. The assay has the advantage of being performed in whole blood rather than plasma alone. So it's arguably a bit more physiological and global. For those not familiar, the blood is placed into a cup and coagulation is activated with, for example, a tissue factor containing reagent. A pin is inserted into the cup and oscillates, inducing at least an element of flow into the system. The oscillations are impeded as the coagulum forms, and this is transmitted into graphics and also time-dependent evaluations of the clot formation. I thought this sounded a lot more like it, and this is the sort of trace that you'll be familiar with seeing with an estimation of clot formation times, clotting time, and to some degree estimation of how strong the clot is with the maximum clot thickness, which is the maximum amplitude. As with the thrombin generation, this gives you a whole lot more data. For example, as I've said, the maximum clot firmness gives some degree of indication of the clot structure and strength. I've also mentioned the advantage that this felt to me to be a little bit more physiological, with it being used in whole blood, introducing that element of flow dynamics within the system. However, there were still a lot of downsides. Much in common with the thrombin generation, we had to be very careful with the pre-analytical variables. But also, paradoxically, I found that the greatest difficulty with using this as a research tool was it was so well validated and well developed. The standard reagents are quite clunky and were a bit blunt. They used quite large amounts of tissue factor, which overwhelmed the effects that we were trying to test, which is the effects of spiking and introducing the investigational products to see their effect. So we had to go down the line of manipulating this a little bit. And I therefore started to look at how to make the assay more sensitive by reducing that tissue factor signal. And I did an awful lot of work on adapting. It sounds like a very, very simple change, but it took an awful lot of titration experiments to adapt just that one little part of the experimental setup. By diluting the tissue factor dose down, we got a very sensitive test. And you can see here, this is just one example of a dose-dependent changes with the addition of various investigational products. In order to do this, however, it was, I would say, almost 3 months of solid pipetting and trial and error, just looking at not only the concentrations, but the reagents, how they're stored, how this manipulation in the sensitivity of the tests affects the reproducibility. So on the downside, we'd taken a very well-validated and reproducible tool and come up with something extremely temperamental. We did found that with a lot of practice, you could achieve good reproducibility, but it took a training and an enormous amount of trial and error. And as I said, it really increased the sensitivity not only to the investigational products, but also to pre-analytical variables, where the smallest deviation in the process could have an effect. So by doing this, I'd got some of the way towards achieving my aim of getting a sensitive and a more physiological representative and global hemostatic assay. And we've introduced an element of cellular function with the whole blood, a little bit of flow dynamics, some assessment of the fibrin structure in terms of the maximum clot firmness, but it didn't feel all the way there yet. To really refine the method, what I really wanted to do was get a little bit more of an assessment of the end product, how stable and functional that clot was. So in order to do that, I tried to refine the method a little bit further, using an evolution of a method described by Mira Chitler and her team, where they added TPA as a challenge to the evolving clot. The assay was simultaneously activated with this minimal amount of tissue factor and then challenged with TPA to produce curves like this. So the blue is a control patient where just the minimal tissue factor assay has been used. The red fish-like curve shows a lysis trail in a normal patient, and the black curve is a patient with haemophilia. Again, we were able to, we calculated the area onto the curve to give a proxy assessment of the clot stability, and the result was a very dose-sensitive assay, as you can see again with these titrations in a single patient on the right. So again, another little element of this global picture built up, and it was a useful tool for answering some of the questions, but in common with the minimal tissue factor assay, it was amazingly temperamental as well. And again, a vast amount of trial and error to produce a reproducible sort of assay. I used these 3 global hemostatic assays as the basis of my research, and at the time was also continuing to work on trying to develop a more sophisticated hemostatic assay with a colleague. And I wanted to just highlight this little bit of equipment, which I think there have been some recent advances in using in some recent publications. This is a flow chamber system, and it has some great advantages and potential to develop and create a physiologically relevant global hemostatic assay. These are really made up of plates with vessel-like tubes and channels within them. These can be coated with a variety of activators or even endothelial cells. Blood is pushed through with a pump through these channels, and you can adapt the shear stress that the cells are under. The microscope and recording equipment means that you can capture in real time the formation of clots potentially in whole blood. We tried to set this up, and if I thought that adapting a ROTEM was difficult to do and standardise, this was a whole new level of complexity. And after a year's work, we just about managed to standardise coating the plates in tissue factor. But there are people who are much more adept at this, who are continuing to work on developing these sorts of assays. So for the moment, I'm going to leave that to them and show you what we did end up using. Rather than generating the ultimate global hemostatic assay, by manipulating and adapting a few different methods, I think we've got a pretty good coverage of this process, with the thrombin generation assay obviously providing a great deal of information about dynamic thrombin changes, with the minimal tissue factor ROTEM introducing an element of flow dynamics, and a little bit of the cellular function, the TPA and tissue factor assessment giving a assessment of the functional clot. In addition, to almost validate these sorts of procedures, we also looked at the physical clot structure that was formed using electron microscopy and evaluations of the pore structure. So rather than achieving the aim of creating one ultimate assay, which I think in retrospect was rather unrealistic, with the process of going through stages of development, we did develop a barrage of tests which overall gave the most global review that I think I could manage. So I hope this reassures you on a number of points. Firstly, even if you're not a biomedical scientist, there's fun to be had with exploring the techniques and seeing where you get. The amount of trial and error is exhausting, but you learn an awful lot and benefit from that process as you're going along in terms of practicing the techniques and really understanding the process of validation. So I don't think it's something to be scared of if you're coming to a research project as a medic without laboratory experience. You may not come up with your original perfect goal, but you make adaptations and find solutions along the way. And I hope this has provided you with the briefest introductions about the possibilities of global hemostatic assays and their potential benefits and drawbacks. So thank you.